kind of, I say the second official week of COVID-19. It's not, we're way further in, but it feels like this is really kind of the second week when everybody is staying at home, when we're really starting to see these changes and disruption. And so, as always, that's what we're really here to talk to you about. We're going to talk specifically today about growing anxiety and when people should seek help. We kind of have gotten a lot of questions overall about when do we start to say this is normal versus I need to seek treatment, and what should treatment look like during this time. And so today we have Dr. Abramowitz from the University of North Carolina with us. We are so lucky to have him. As many of you know, Dr. Abramowitz developed the dimensional OCD scale, is an author of many different books and self-help books and workbooks and all of that. And so we are so excited to have you. Thank you for joining us today.
Thanks for having me, Liz. Happy to be here.
Well, tell us a little bit about how you're doing. I think I always want to have a little check-in with people of just especially I think it's helpful for people in the OCD and anxiety community to hear from professionals about how we're managing this and what this has been like for us.
Definitely. It's been a time. It's been different. I feel like I'm managing okay. I have a family of a wife and two daughters that are teenagers, and generally, we've kind of been able to manage having each other around. My older daughter's usually in college, so she's back now. So we're all kind of cooped up. We get out and exercise a lot. We exercise in our house a lot. I think that's a really healthy coping strategy. As far as anxiety goes, I'm managing okay. I guess there's some days when I kind of feel a little down and a little worried about, what's going to happen with like the rest of our lives, and will we get back to normal, and how's that going to be? But again, I think those times are kind of few and far between. In general, hopefully this is a temporary thing, and I have hope for society and all of that. So, I don't know. I feel like I'm coping okay. As far as like, just kind of switching everything to working at home, that's gone okay for me. Luckily, that's been fairly seamless. So good. I don't know. How are you doing?
Figuring it out. I think that we've been telling people, thank goodness this happened now versus 15 years ago, because of Zoom and different platforms, we can do most of our stuff online. It doesn't mean it's not different. I think that for those of us that are in a lot of direct clinical practice, we had a residential support, and we have an IOP and an outpatient. And so for us, we've moved everything online, but of course our residential support's closed down in the time being. And so we're just anxiously awaiting when we can safely bring everybody back, because I think we're longing for that in-person touch. But I always say, and I think I heard you say it a little bit, there's silver lining in everything. And it sounds like for you guys, right, you have your whole family together, which normally wouldn't happen right now, and you're spending time together. And I've been kind of helping all of those of us with OCD recognize the silver lining in this. I've been saying over and over, home visits are really expensive, and most of us can't afford home visits on a normal basis. But hey, like teletherapy, you're getting home visits at the same cost.
Yeah, and I think that, some things are bound to change once we do get out of this. I think maybe for the better, people are going to be using teletherapy, using Zoom and things like that to do therapy more often than they are now, because we've gotten used to it. So I don't know, maybe some good will come out of this.
Yeah, 100%. So we have a lot of questions that were submitted today. As always, people can submit any live questions on the right. And so we'll kind of try to manage them as we can. But again, thank you for your time and your service to our community. We are excited to have you. All right. So the first is, how do we recognize anxiety in ourselves, our loved ones, or our children? And how do we kind of cope with it in a healthy way? I think the first normal thing that it's important for us to talk about is just normalizing that anxiety right now makes sense, right? That there's part of that that's healthy, right? It'd be strange if we had no anxiety during this time. But how do we help ease anxiety during this time? I think a lot of us, we've talked a little bit in some of the previous webinars last week with Dr. Wagner about how anxiety responds to other people's anxiety as well. And so how overall should we recognize it and respond as a household?
Yeah, well, I'm actually but I completely agree with what you said. I'll take it one step further. Anxiety is a normal emotion. It's a response. It's not only is normal, I mean, we need it. It's life-saving. It's our response to the perception of threat. And so, of course, we call it the fight or flight response, or stress or worry or fear. all of those emotions, they're all really the same thing, and they all serve a purpose to keep us safe. If there was really some sort of danger, right, we need that fight or flight activation in order to get us away. In ancient times, the saber-toothed tigers were around, and if we didn't become anxious when we saw one, if we weren't afraid, then we wouldn't be here now, because the humans would all have been eaten by the saber-toothed tigers. So I think the first thing to recognize is, as you said, Liz, anxiety is completely normal, and especially at a time like this, it's not necessarily irrational anxiety either. So it's normal to feel anxious, normal to feel stressed. And a lot of people mistake those uncomfortable anxiety sensations, your heart's pounding, maybe you have muscle tension, maybe trouble catching your breath. We don't want to mistake those for anything dangerous. That's just part of your fight or flight response.
I think people with OCD and anxiety have learned this, right? So one of the things Dr. Grayson talked about last week when we did a webinar with him was, we're more equipped to handle some of these anxiety because we've learned through treatment, right? Those of us that have been in appropriate treatment, we've learned that sure, anxiety is there and anxiety is real, but that you don't always have to respond to it, right? And I think that's a question of like, how do we teach people who haven't been in treatment, haven't done the same amount of work? How do we teach them that tool?
Yeah, I think it's a matter of learning to understand what your body's telling you, right? That you're perceiving some sort of threat. So whether it has to do with the virus, or whether it has to do with something maybe related to a problem with anxiety that you've got, that perception of threat is what's kind of triggering you to feel anxious. And so using that feeling of anxiety as kind of a cue to go back and say, okay, what am I telling myself? And that kind of comes from this cognitive behavioral therapy angle that starts with your emotion. And then you have to think about what are the situations and what are the beliefs, the thoughts and interpretations that you have that leading you to feel anxious. And so first, understanding that anxiety is normal. It's not going to harm you at all. Anxiety is not dangerous. And to understand where that's coming from. So what are you telling yourself? What are those thoughts going through your head that are leading you to feel that way?
So any tips or like quick tools right now for people who are feeling anxious, they're recognizing it as anxiety, they're not necessarily responding. What do they do? For OCD, we tell people live with it, feel it, let it be, right? That's part of the ERP. And we're actually kind of not trying to combat it with anything, even mindfulness in that moment, because we want you to feel the anxiety. How do people who don't have those same tools, like what are just some quick ways they can understand how to address it?
Yeah, exercise I think is a great thing to do. Get out, take a walk. It's a beautiful day where I live in North Carolina right now. Get out, take a walk. There are wonderful like YouTube videos that have somebody leading you through exercises that you can do in your house. You don't need any equipment or anything like that. If there are things that you enjoy, like a TV show that makes you laugh, or just another person in your house that you can spend time with, it's perfectly great to do those things. Throw yourself into some activity. We've been doing a lot of cooking and baking around here just because we're all together and it's a fun activity to do as a family. So those are always some nice things to do. Picking up a book. Those are always some good things that you can do as well.
Wonderful. And what are tips that you might have on when someone should seek help, right? So when and how, like what are some things, just quick little tools, but things to look for that say, okay, at this point you should consider seeing a provider versus doing some behavioral activation and some things on your own?
Yeah, if you're starting to notice that the anxiety is getting in the way of things like your appetite, your sleep patterns, maybe your relationships because maybe you're frustrated and you get angry, kind of lose your cool a little easily. If the anxiety is getting to the point where you feel like, hey, I don't, this is too much. I shouldn't be feeling anxious, so often, so many times throughout the day or so much of the day. But it's really a judgment call. Everyone's going to have that threshold for when they feel like they want to seek help. It's going to be different for everybody. It's a subjective call. And there's no harm. There's no harm in getting in touch with a provider to find out, hey, is this anxiety too much, or am I just, is this something that I can manage on my own?
Yeah, and I think that's really important for us to recognize, right? Is that during this time when you're feeling, I always say exactly that, but really it's a judgment call of when is it interfering with my life, right? And so how it interferes is different for everybody. As you said, sometimes it's the way you're sleeping, you're eating. For some people, it's work, right? Maybe you're not able to focus on work at all, and you're like, this is disruptive. I've got to address it. But the reality is that just because you're seeking out a provider does not necessarily mean now that you're committed to therapy forever, right? Sometimes if you're experiencing a lower level of anxiety and you catch it earlier, we'll be able to give you some tools and get you in and out in a few sessions.
And it's perfectly appropriate. That's exactly right. Perfectly appropriate to have a consultation without the expectation that you're going to come back for therapy over and over again for follow-up visits. Hey, what can I do to address this, quickly? If and sometimes there's not a quick fix. That's another thing that I run into. Sometimes people, they want a quick fix. And what I have to explain is that, first of all, anxiety is something that you need. So it's not just about like, let's push it away all the time. We know that that's not such a great strategy, but also that it takes time, just like you're learning how to play a musical instrument or learning how to play a sport. To manage anxiety, whether it's OCD or other sorts of anxiety, takes time and practice, a lot of work and practice.
And it's actually not comfortable or what we usually want. I think patients' first reaction when they come to our clinics and we say, the goal of treatment is actually not to get rid of anxiety. It's to learn to be okay with anxiety. Their response is like, what? That's not what I came here for, right? I came here for you to fix my anxiety, for you to get rid of it. But really what you're saying is 100% accurate in what we all have to understand, which is that anxiety is normal. Anxiety is healthy, right? Now, for many of us, anxiety becomes disruptive and anxiety becomes unhealthy. And that's certainly when we need to seek treatment. But treatment isn't about making you never feel anxiety, right? And certainly medications that sometimes people are prescribed that stop the feeling of anxiety don't really help that much either in the long run.
Yeah, you got it. I always tell people that it's not about fixing anxiety. It's about being better at anxiety, being better, having a better relationship to your anxiety so that you know how to manage it and you know that it is safe and manageable. Right. And I totally want to agree with you, using things like the benzodiazepines, for example. So, Xanax and Klonopin and things like that. Prescribers sometimes recommend those because they do get rid of anxiety in the moment really quickly. Unfortunately, the really unfortunate side effect is that they actually teach people that anxiety is bad and that you can't cope with anxiety, which is not a good long-term strategy because you don't want to get rid of anxiety. It's ultimately a helpful, healthy, and safe thing.
Right. And I think that, just like that teaches anxiety, we see behaviors or rituals do the same, right? That sometimes these rituals that we do are actually teaching us that we need to respond, that we need to do something versus just letting it be.
You got it. That's exactly right.
Okay, so we have a lot of questions. So I want to answer some of those. Are you hearing an echo? I'm hearing a little bit of an echo.
But
phone, I've got everything going on. So, okay. First question is, what about images of OCD related to pure O? Can we talk a little bit about this type of OCD? And what do you think about antipsychotic medications in addition to the treatment of OCD images? I think since we're not medical professionals, we won't go into the medication a bit more if we can just answer pure O and, the previous, I say pure O, we don't really call it that anymore, but treatment.
And what was the specific question? I kind of lost you for just a second there. About pure O.
The specific question is just how do you deal with these images? So how do you deal with this type of OCD, and can we talk about tools for it?
Okay, so first I think let's address what you brought up about how pure O is not really pure O. People call it pure obsessions based on the idea that a lot of people who have this subtype of OCD have lots of obsessional thoughts, these unwanted images. Often they have to do with like morality or religion or sex or violence. And they don't have the typical washing and checking or repeating actions, compulsions. A lot of the compulsions are mental rituals. But I think it's a misnomer to say pure obsessions because there's a lot more going on than just those obsessional thoughts. People are spending a lot of time trying to push those thoughts away. It might be by avoiding things. It might be in your head of doing some sort of like thought suppression or neutralizing behavior in your mind or a mental ritual. And so pure obsessions, I don't like that term either. I think that's a misnomer. What do we do? The treatment of choice for this kind of presentation of OCD is really learning also that these unwanted thoughts, these images, they're also safe, they're harmless, they're really unpleasant, but they're not dangerous at all. They don't mean that, if you have some sort of unwanted thought, that's going to become who you are. You're going to act on it or change your personality or change your sexual preference or harm someone or stuff like that. So the treatment is about leaning into those thoughts, bringing them on, usually by exposure, if not actually exposing yourself to a situation that provokes the thought, but then instead maybe you're writing a scenario that triggers that, and then leaning into it and learning these thoughts are safe and manageable. The anxiety that comes with them is safe and manageable, and the uncertainty that comes with them is also safe and manageable. Even if it's uncomfortable, I can get through this. It's temporary, and the thing to do is to lean into it rather than push it away, because we know that doesn't work. So it's really, an adaptation of typical exposure therapy, exposure
Right.
response therapy.
Right. And I think it's so important for us to recognize, right, that this the reason a lot of us don't love it is just because it gives the illusion that there's not rituals. But the reality is that a mental ritual serves OCD the same as a physical ritual. So ERP really looks the same, right? It might look a little bit different, but it works the same way. And it's still resisting those rituals, even if they're rumination or mental.
You got it.
So the next question, someone had a comment that just says, I'm amazed at how well I've been handling this. Not saying it's easy, but I'm actually doing the things professionals said I could. And I think there's really important for us to speak to that for a second, just because I do think that we're seeing people, especially those of us with OCD, a lot of people with contamination OCD, this is one of their worst fears, right? They've been worried about these kind of viruses, these contagious, elements that could be contracted and given to someone else, and that we could, right, the reality of the world is something we've often feared. And most of us in treatment have said, oh, well, that's pretty low risk, right? But right now, okay, it's higher risk. Yeah. And so I just wonder what your thoughts are on, why we see so many people with OCD that this has always been their fear, no longer, not necessarily that it's not a fear for them, but like now that it's actually happening, it's like, oh, like, I can handle this, right? Like, it doesn't mean it's easy. It's not easy for anyone, but I can manage it. And can you speak a little bit to anticipatory anxiety and what that often causes across the board?
Yeah, it's a great question. And it's interesting because I have noticed that with the people that I work with who have OCD about contamination, that they're not as worried about this as I would have predicted. And, in trying to wrap my head around that, I come up with a few things. Number one, something that we've always known is a big part of OCD is this intolerance of uncertainty. And it's like the unknown is almost worse than knowing that, you could be contaminated. And I guess an analogy would be for someone who has health anxiety, like not knowing if I actually have cancer is worse than having a diagnosis of cancer, and then I know at least what I need to do about it. And so, one of the things that I don't know, that I've been thinking about is with this COVID-19 business, like of course there's uncertainty, but we're given some sort of strategies for, here's the rules, here's what you're supposed to do, here's what you're not supposed to do. And so, and maybe all this is a ritual and maybe the risk really is low, but we're all being told, we're all in the same boat, we're all being told how to manage this, and it kind of makes it a little bit easier for folks to manage, rather than, did I wash enough, did I have I avoided enough? So I think that's one thing. And I guess to kind of take a broader picture, people with OCD, they know what to do when there's actual danger out there. That's not the problem with OCD. The problem is when there's when it's questionable, they set their bar too high to try to get that certainty. That's not possible. But when there is real danger, folks with OCD, they know how to manage that. That's not the question.
And I love that. And I think, those of us that treat OCD, we see that over and over again, where the things that our patients are most worried about, when it actually happens, they're able to say after, like, I did fine, right? Like it was hard. It might've been triggering, but I managed it just fine. And I know I did a good job. And so that says a lot. The next question is that they're from Jordan. This family's from Jordan. And their daughter hasn't gone through the right therapy and is trying now to do ERP on their own. Some of the apps they've been using aren't working. Do we have any recommendations for online, or maybe you can talk a little bit about self-help books and workbooks?
Yeah, there are, there are some good self-help books and workbooks and things like that. I'll pat my own back and say that I've written one called Getting Over OCD, but there are a number of good ones. Jonathan Grayson has written one that I really like. It's called Freedom from Obsessive Compulsive Disorder. I'm not doing it justice by not mentioning some other good ones that are not coming to mind. But the International OCD Foundation, IOCDF, has a website where they have these resources listed out, and I recommend that. The Association for Behavioral and Cognitive Therapies, abct.org, also has a list of kind of their approved self-help books. As far as apps, I'm not as familiar with the world of apps. I think there's one called NOCD, NoCD. I think there are probably some others, but that's not something that I know a heck of a lot about. So I don't want to endorse anyone over another.
Yeah, and I think I will say, I'll just reinforce what you just said. So Dr. Grayson's book is one that's wonderful, Freedom from OCD, and we talked about this last week. I love that his book does a really good job, I think, in particular for scripts, and really allowing people to understand how do we incorporate scripts into ERP and what do they look like. And then Jon's self-help workbook is absolutely incredible. It's what we use at our clinic and give to all of our patients. And I think, the old workbooks are good too. The OCD workbook is the original one from a long time ago, but Dr. Abramowitz's is updated, and it has new kind of content and ways that we think about treatment that's even better. So I think that those are both wonderful. And then, of course, Peace of Mind does the same thing. So IOCDF and Peace of Mind, we work to kind of keep these resources together. But I do think two things are really important to know. The first is that self-help is not usually intended to replace face-to-face therapy. And oftentimes for people with OCD, it is really helpful to kind of meet with someone just to get the basics and understand, what does a hierarchy look like? What would my hierarchy look like? And once you get the basics, these tools are even more useful. And so if you're from Jordan, sometimes there are teletherapy options and clinicians in the US who actually can do teletherapy across international borders much easier than state borders. And so definitely also look into some of the teletherapy resources that are available. And then, of course, the Peace of Mind Foundation, we have OCD Challenge, which is our online interactive application that Dr. Mindy Stanley and Dr. Marty Franklin and lots of people in the field came together to develop, that works on ERP. But again, teletherapy, I would highly recommend during this time, because most clinicians are doing it sometimes for the first time ever. All right, so a little bit of questions as well around intrusive thoughts, and we talked a little bit about that. Let's kind of keep moving on. Charities, gonna add, we've got questions from like two different angles, so I'll kind of go to the other ones. But any thoughts, Jon, on activities or strategies that really people can incorporate to create this good work-life balance and taking care of themselves, especially with kids homeschooling? A lot of parents are talking about anxiety they've never felt for the first time. They are a stay-at-home mom, a wife, the chef, the cleaning person, and the teacher, and they are wondering how they got this role and feeling overwhelmed. How can moms, let's go specifically to moms, but how can moms manage their anxiety?
Yeah, you've got to find some way to make time for yourself. It's not selfish. You'll be a better parent to the extent that you can find some time, even if it's just a half hour, hour a day, where you get a chance to do something on your own. If that's not, if you have smaller kids and you can't leave them alone, but go out of the house, then maybe have some sort of, Zoom or, online meetup with a friend or something like that, where you can just do something that's going to be for you. I just think that's so important because it really is. My heart goes out to, I mean, I have older kids, and I remember when they were younger, and wow, my heart goes out to folks that are just kind of stuck at home, especially if you're a single parent. That must be really difficult. And you gotta find, maybe during nap time, or sit someone in front of the TV for a little while, or give them your iPad to play with, or something like that, where you get a chance to go and do something that you enjoy. You got to do that every day, and make sure that you have time for yourself. I think that's the most important thing. If you have a partner, then you got to trade off. That's just, you got to have some sort of schedule that you work out. Here's going to be my time. Here's going to be your time. Here's going to be when we're going to work together. It's going to be so important to communicate with your partner and make sure that you're giving each other time off. Otherwise, that stress is going to build up, and it's going to be, really unpleasant in there and difficult to manage.
Absolutely. One of the next questions is this patient recently completed treatment at an intensive treatment program, residential program, and they're feeling really anxious to leave their home. In particular, they're really afraid that all their success from the program is going to go away and that they may experience a relapse. They said specifically they're feeling like, especially at night, they're waking up with nightmares and panic attacks. And so I think the question is really about, how do we continue the treatment we've learned when things have been disrupted, right? Maybe our plan that was originally in place around, relapse prevention has totally been disrupted during this time, but how do we keep it up and not let the fear or anxiety stop us from doing ERP at all?
Yeah, well, I mean, to your point, it really is important to keep that up. Just because you're finished at a residential program, and congratulations, hopefully things went well, the therapy is never really finished. You want to continue to always kind of have a lifestyle of exposure and response prevention. I think that's what folks who don't have OCD, that's kind of what they do on autopilot. And it's only when you have OCD that you begin to develop these avoidance and ritual strategies that kind of keep you from learning what folks without OCD have learned, that I can manage anxiety, I can manage uncertainty, the risk is low. So you want to figure out whatever you can do to continue to put yourself in situations where you have an opportunity to teach yourself, I can manage anxiety, I can manage uncertainty, and I can manage the risk of, whatever it is that I'm worried about, proving to yourself again and again and again, the risk is manageable. I can get through this. And this is going to be a rough, now we're hearing it'll be another month or so that we're going to be like in this quarantine, and who knows how long it's going to go on. Yeah. And it's absolutely going to make things rougher for folks with OCD and anxiety. Being creative, finding a way to push through, getting in touch with a professional who can maybe give you some pointers on how to do that depending on the type of OCD symptoms that you have. I think it's really important to keep that, keep working. Don't take your foot off the gas as much as possible.
I think that's critical. And I love the webinar we did last week with Dr. Grayson. I encourage people to watch this one as well, because he really, really walked you through how you can do ERP at home, right? He talked a little bit about, CDC guidelines exist, right? We're hand washing more than we ever have before. But once you get home, you do your hand wash, you're at home, and we can do ERP in your home environment. And so I think a lot of us get kind of, tunnel vision of like, okay, my circumstances have changed, so I can't continue with therapy because now I'm stuck at home. Yes, you can. And that's what I want you to hear. Dr. Abramowitz, Dr. Grayson, Dr. Wagner, everyone who's spoken has said the same thing, right? Teletherapy is available. We can still do ERP in these circumstances, sometimes better than any other situation, because we get to do it in your home. And so don't give up. Don't stop fighting, right? This is not a time. I've been saying over and over, my kind of quote, I feel like during this time has been, do not let this be an excuse to put treatment on hold. Yeah. If anything, this is an opportunity for us to do treatment more than ever before, because we have more free time. We have more flexibility, and so do our providers, right? Where we can be available when they are, because it's just a Zoom or whatever, however they're doing it. And don't let this be don't use this as an excuse, because we know that if we take a break, treatment will increase. And that actually brings me specifically to the next question, which was, should we cut our loved ones who have OCD a break while we're in this crisis? And how do we kind of manage that? And I think that's a great question. I think parents are probably feeling anxious. They probably are a lot more apt to give reassurance right now to kind of, give into OCD a little bit more. But can you talk a little bit about how they should manage that?
It's a great question. And the answer is no, you don't want to accommodate. You don't want to do rituals for your loved one. Obviously, it's smart to follow the rules, right? The CDC rules, the guidelines, definitely follow those. But, if you have a loved one who has, let's say, washing rituals and contamination fears, maybe they're afraid of, I don't know, something around the house, a toilet, a shirt. After you wash your hands, recontaminate, right? There's no reason you shouldn't be doing that. And your point, I hadn't thought about that, but your point about doing exposure in your house, right? As long as you're not having, gatherings of more than 10 people and things like that, your house should be relatively low risk, acceptably low risk. And so there's nothing wrong with getting contaminated with things around the house, spreading that contamination around. So absolutely, this is not a time to give up, not a time to accommodate. And so you want to keep this up.
Yeah, it's actually probably the best time to really speed up, right? To use this as a chance that, like, hey, during this time when I've got free time, I'm gonna get as strong of a hold as I can over my OCD. Not I'll deal with it later.
And it's really a chance to learn even more. We think about this way of thinking about exposure from an inhibitory learning perspective. Here's a chance where you have an opportunity to learn that I'm killing two birds with one stone. I'm learning how to manage this COVID-19 stuff and my OCD symptoms in an opportunity where there are extra things that could be contaminating. I can get through that also, and I think that's kind of a cherry on top of the sundae, I guess, of doing exposure therapy. It can be extra helpful. So absolutely, keep your foot on the gas.
100%. And this leads us actually into our next questions, which are both about inhibitory learning. So can you first just kind of describe inhibitory learning, or maybe kind of define what it is and what it means?
Sure. Inhibitory learning is a way of thinking about exposure therapy. And all it is, it's a really, really, when we do exposure therapy, we want people to, in a way that disconfirm fear. And in the past, we used to think that exposure therapy was all about habituation. So go and confront touch the floor, or do your exposure, and your anxiety comes up and it comes down, and boom, that's all you need. Turns out that's not what you need. Doesn't matter if anxiety comes down or goes up. What's more important is that you learn that your prediction of what's going to happen is not likely to happen. And those predictions can fall into three categories. It could be that there's actually something bad's going to happen to me. It could be that the anxiety, can be. And when we do inhibitory learning-based exposure, we're setting up the exposures to deliberately disconfirm those three kinds of things. It looks very similar to the old way of doing exposure, but kind of conceptually, and there are some differences, but conceptually it's kind of different, because we're not just relying on your SUDS, right? Subjective units of discomfort. We're not relying on that anxiety to come down. We don't care if the anxiety goes down. If the anxiety stays up, then we learn, I can manage anxiety. So that's kind of what we're going for. That's a
wonderful.
Quick read, like on the IOCDF website. I've written some stuff about inhibitory learning if you want the long and boring version.
Well, I'll ask the second question, which you may have answered, but from a patient's perspective, how does approaching ERB from an inhibitory learning perspective, instead of an emotional processing perspective, affect how they would perform the specific exposures? They said, I've been reading the second editions of your books, and I wanted to ask my therapist how this affects the idea of habituation.
Yeah, so that's the main thing, is that we're not worried about habituation. When I was trained how to do exposure therapy, it was all about, we got to stay in the situation, stay in the exposure until that anxiety comes down. What's your SUDS? How you doing now? Has it come down yet? And the thinking was, that when the suds came down, and repeatedly suds would come down, that was the same thing as learning not to be afraid. And now we know from, years worth of research and research on how human beings learn to not be afraid, and animals, other animals too, we've learned that habituation is not the same thing as learning not to be afraid. Learning not to be afraid is a cognitive change that involves extinction, which basically means you have a prediction about something bad. You have an expectation about something bad is going to happen. I am going to turn into a murderer if I think about murdering my wife in her sleep. That's my prediction. So I'm going to do exposure to anything I can to disconfirm that. So my wife is sleeping there soundly, and I've got a knife on my side of the, under my pillow. And I'm going to wake up in the middle of the night while she's sleeping. And I'm going to read a story about me, stabbing her and all that. And I'm going to learn, right, that no, I'm just the same old nice guy who has a knife under his pillow and is reading a nasty story, rather than turning into a murderer. And in inhibitory learning exposure, what we're doing is we're helping the person to basically disconfirm those expectations. And that's the main difference.
Yeah, and I think it's important for us to note too that sometimes habituation, right, it doesn't look the way we always want it to look, right? And I think some people get concerned about that, and this is a new way of thinking. But I do want to just point out the importance of understanding that sometimes our anxiety levels aren't decreasing because we're ritualizing, right? So this is still talking about not ritualizing. So we're still having the response prevention. It doesn't mean, okay, my anxiety stayed really high because I continued to ruminate, and that's okay because I kind of gave myself enough reassurance until I learned, right? That's not going to get us where we need to be.
That's right, because if you ritualize, then that prevents you from learning what you got to learn. So if I say a prayer before I do that bedtime knife exposure, then when I don't stab my wife, I could say to myself, woo, that was a near miss. I'm glad I prayed, otherwise I would have done it. And so the ritual keeps me from learning that I'm actually safe, and that, nothing's going to happen. So absolutely, we got to still stop the rituals.
Right.
Yeah.
Well, wonderful. Well, thank you for sharing that. I think that's very helpful, and lots of people. A couple questions I can answer. One is about teletherapy for individuals with Medicaid or Medicare. So what I will say is, please send us an email to info@peaceofmind.com, and please continue to check iocdf.org and peaceofmind.com as we will continue to update resources and support. There are certainly providers who accept Medicaid, Medicare for OCD. I don't know what it'll look like on a virtual standpoint, and so we'll have to help you navigate that system, but I'm a big believer that that exists. I will also say lots and lots of people are doing online support groups right now. They already existed, but even more are available. So there's a lot of options that previously were not. Any kind of last minute tips, advice, or thoughts, Dr. Abramowitz, before we wrap up today on kind of recognizing anxiety, recognizing OCD, but continuing to do the work you need to do so that it doesn't become overbearing? I think the thought process that we can recognize it and that's okay, versus us waiting to recognize it until it's not as much okay.
Yeah, I think making sure that you're kind of checking in with yourself and seeing how you're doing, and not being afraid to reach out, whether it's through self-help resources, reaching out to a professional. Liz, you're awesome, and Peace of Mind does a great job spreading the word of all this. So, people should use that resource, absolutely. And I appreciate being included today.
Well, thank you. Thank you for your time. I know that we've all got a lot going on, so we certainly appreciate you doing this. And this video, as all of them, will be available later at iocdf.org, IOCDF's Facebook page, and Peace of Mind's Facebook page, and peaceofmind.com. Thank you so much, Dr. Abramowitz. And to everybody, my words of advice always remain the same. Help and hope are always available, even during a time like this. Do not put your treatment on hold. Instead, take this as an opportunity to dive right in. Thank you. Have a great day.